The pharmacokinetics of CAR T is really very different than standard drugs. So CARs are really what's called a living drug. So you can give them one time, and our first patient with leukemia, treated in the summer of 2010, still has CAR T cells in the patient, and we can show they're still functioning. So that's very different than drugs that you have to give recursively because they get metabolized. Unlike standard drugs, what we reported was the CAR T cells go up, reach a maximum concentration around 10 days after infusion, and then have very slow decay kinetics. In solid tumors it may be different, but at least in the bone marrow tumors we've seen similar kinetics for acute leukemia and chronic leukemia and myeloma. This is an area that's evolving, which will be closely monitoring patients to follow the status of their CAR cells. CAR T cells, I think, will be given earlier and earlier. Right now they're given for very advanced cancers, but I think what we'll find out is that they're safer than the alternative forms of therapy, such as chemotherapy. So one aspect is to move them front line, and there are trials already started for that in pediatric leukemia. Right now they get 2 to 3 years of intensive chemoradiotherapy, and that could potentially be replaced with a single infusion of CAR cells. So that probably will happen. But even farther down the line, as CARs and engineered cells in general could be used as a form of a vaccine. So for instance, women who have risk of familial, say, breast and ovarian cancer could in potential be treated prophylactically if they're found to carry the genes that put them at risk with an infusion of engineered cells that could prevent those kinds of hereditary cancers.